Welcome to the LDN radio show, brought to you by the LDN Research Trust. I'm your host, Linda Elseygood. I have an exciting lineup of guest speakers who are LDN experts in their field. We will be discussing low-dose naltrexone and its many uses in autoimmune diseases, cancers, etc. You're invited to join us on air, asking your questions by calling in on the local rate phone numbers in the UK and the US, which can be found on ldnradio.org. Thank you for joining us. Today our guest is Dr. Richard Nahas from Ottawa in Canada. The Seeker Centre, led by Dr. Richard Nahas in Ottawa, Canada, focuses on pain and the brain by providing assessment and treatment of disorders of the nervous system, using evidence-based integrative medicine and self-care protocols. They're engaged in advocacy, clinical training, research projects and medical education. Call 613-727-7246 extension 114 or visit www.seekerscentre.com. Well, thank you for joining us today, Dr. Richard Nahas. What a pleasure it is to have you with us.
It's great to be here. Thank you.
I've interviewed you in the past, and it's very interesting what you do there. I know that now you're working with, should we say, brain health. Before we get into what it is you're actually doing now at the Seekers Centre, could you tell us who Dr. Richard Nahas is? Everybody likes to know who the doctor is, you know, what made you become a doctor, what makes you tick?
Well, I have always been curious and had no real clear idea what I wanted to do with my life, but really enjoyed science and decided that medicine was as good a choice as any, and really on a lark decided, without too much knowledge of what I was getting into, to become a doctor. And fortunately, I found a path that suited my temperament and my needs. I became an ER physician for 5 years in Toronto. I was a full-time ER doctor. And then in 2004, when the SARS crisis came to Toronto and my emergency department was closed, I took a job looking after SARS patients. And the CDC was there, and I was wearing a spacesuit to do assessments. It was quite something. Mm-hmm. And when all was said and done and we looked at the data, we recognized that the odds of dying of SARS were doubled if you were diabetic. And so this was kind of a light bulb moment for me, where, you know, you have this very quintessential Western approach to disease, that the virus is killing people. And we see that in diabetics, half the deaths were not due to the virus, but rather due to their inability to bounce back because of their condition. So I decided to focus a little more on so-called wellness and try to understand how we can help the body heal itself. And I paired that with a backpacking trip I had always wanted to take. I traveled for a couple of years and learned a lot of things in many countries, and came back to open my center, where I've been working for about a dozen years now. And we continue with our clinical practice, and I feel very gratified to see good results in my patients. But we're more moving towards developing tools to help CAM providers and other health professionals document what they do and have their patients track their outcomes using mobile tools so we can figure out what works and what doesn't. Because naltrexone is one of many tools that has great potential that, as you know, would benefit greatly from more data in more patients.
And when did you first start prescribing LDN?
Very early on in my integrative career, actually. I spent some time with a colleague in Toronto, and that has been something that has been helpful to me, visiting other colleagues and seeing what they do. And so I've been tuned into LDN for about a decade.
And when you first started prescribing LDN, what conditions were you mainly treating at that time?
Well, I had a general practice that means that anyone who had a chronic health problem that wasn't responding to standard care, or who had unacceptable side effects, who wanted to explore alternatives and wanted to do that with a doctor, would come see me. So primarily autoimmune disease and cancer at first. And I've seen positive responses in autoimmune disease for sure. Tougher to tell with cancer because there's so many other factors going on. But I was, you see a few case reports in your own practice, and that's not necessarily the same kind of evidence as a double-blind study, but it is a form of evidence that can be useful in clinical practice. So I was convinced early on that there was something there.
And then, of course, your practice has evolved over time. I've actually interviewed you twice before, and the last time you were talking about brain health, which I found really fascinating. I've been reading on your website, and I was wondering if you would describe for us, the people that perhaps haven't been to your website. You talk about functional brain assessment. What does that actually involve? What does it mean?
Well, we can take pictures of the brain with a CT scan or an MRI, and that can tell us a lot about brain anatomy. But we have very few tests that actually tell us about brain function. On a very gross level, we can tell whether a patient's brain is abnormal or not by looking at basic neurologic examination. So muscle strength, reflexes, assessing the cranial nerves, looking for deficits in sensation. But the inside joke in neurology is that most people who have neurologic complaints unfortunately have a normal neurologic examination. Of course, there are many who have neurologic findings, but many people who struggle with health problems are told that nothing can be found that's wrong with them. So a functional brain assessment involves a number of different tests that allow us to see how well the brain is working. And the most straightforward and I think one of the more important parts of the assessment is called a quantitative EEG, or an electroencephalogram. And in medicine, we've used EEGs for decades, but what we end up getting is a printed tracing of waves, sort of like the ECG that you get of your heart. And those waves are visually examined and scanned by neurologists to look for spikes that you would see in seizures. So basically, in medicine, the most common reason to do an EEG is to identify a seizure disorder. Sometimes they'll do it to try to identify how depressed brain function is in coma in intensive care, but it's really not used in regular people. But since the 1970s, there's been software available that will analyze that waveform and use some fancy mathematics called fast Fourier transform to break up that wave into all of its component waves, meaning we can tell how much of your brain is devoted to delta waves, which are predominant in deep sleep, or theta waves, which are predominant in drowsy slumber, or alpha waves, which are more related to calm focus when you're in the zone, beta waves when you're tense and reacting to a stimulus. And those are all different frequencies of waves. So when you look at the brain and you measure at 19 different spots on the head what is happening electrically, you can create a very complex image of the brain that allows you to say, well, this particular area looks abnormal, which we may see after a concussion in someone who otherwise looks normal. Or you could say it looks like there's a very big asymmetry. The left side of your brain is working much harder than the right, which can be associated with autoimmune problems on one side, as is the case in MS. Or we can see that the brain is much slower than it needs to be. And so that all of that information is used to put together a treatment plan to train the brain back to normal. It's called neurofeedback or EEG biofeedback. And so that's something that's available in most communities of decent size. There are neurofeedback providers around the world. And in our case, we're hoping to provide patients with a tool that they can use to get answers and get treatment when other things haven't been helpful.
Mm-hmm. So do you use it to diagnose conditions, or do people come to you with, let's say, MS, and then you have a look at the brain, or can they feel that there's something wrong with them and you can actually diagnose it?
It's a good question. No one is really comfortable with the notion that a QEEG can make a diagnosis by itself. Mm-hmm. But in fact, in many cases, neither can an MRI or an X-ray. Usually, there are findings that the radiologist will say require clinical correlation, which means you look at a patient's symptoms, you look at their diagnosis, you look at their QEEG, and you make a decision about whether there may be something else going on here, right? So in many patients with chronic pain, and this is how we became interested in this, it's very common to see things like fatigue or depression or anxiety or sleep disturbance. And those are key symptoms that we also see in post-concussion syndrome. And so teasing apart who has pain versus who has pain and PCS, because many patients don't even remember having a head injury, can be very helpful. So it's more about identifying whether the brain looks normal or abnormal. And if it looks abnormal, trying to put together what the picture you see on the QEEG with the picture you see in the patient, and then perhaps revising the diagnosis or considering some new factor that hasn't been considered. And then thirdly, planning a treatment plan if it's indicated with neurofeedback.
Okay. Well, we'll just have a quick break and we'll be back in just a minute. To listen to individual radio shows and interviews, go to www.mixcloud.com/LDNRT. I'll repeat that. It's www.mixcloud.com/LDNRT. The Seeker Centre, led by Dr. Richard Nahas in Ottawa, Canada, focuses on pain and the brain by providing assessment and treatment of disorders of the nervous system, using evidence-based integrative medicine and self-care protocols. They're engaged in advocacy, clinical training, research projects and medical education. Call 613-727-7246 extension 114 or visit www.seekerscentre.com. Thank you. Welcome back. This is so interesting. And reading on your website, you did mention pain there. It says MVA High Risk Pain Clinic. Could you explain what that is, please?
Sure. We focus on a very specific patient population in that program for a couple of reasons. One is that we have been getting referrals from other doctors as a chronic pain clinic to help manage people who suffer from chronic pain after a motor vehicle accident. And when it's been 3 or 4 years that someone has been struggling with a syndrome like this, we have two problems as doctors. We have to help rebuild their health, but we also have to help them rebuild their lives, because in many cases their lives have fallen apart because they just can't function. So it affects them at work, at home, with their families, in their communities, their sense of self, their motivation, their willingness to try, and the temptation to give up is very significant. So we would rather see these patients sooner than later. So I'm speaking with ER physicians in our area and doctors who work in walk-in clinics who will see patients the same day or in the first few days after a car accident. And I'm asking them to send patients to us if they look like they're more than just a whiplash injury. So if they have features of post-concussion syndrome or post-traumatic stress disorder that looks like their brain is more affected than just because of pain. So visual symptoms, double vision, blurry vision, trouble reading or looking at screens, those are not problems that you get when you only have a whiplash injury. Tinnitus or ringing of the ears, dizziness, vertigo, nausea, those are called vestibular symptoms. And they're related to the balance apparatus that connects the ears and the sinuses inside the face. And those are also not a part of most chronic pain syndromes. So high-risk patients are people who either manifest symptoms of PCS or PTSD, or people who you can just tell are not going to do well, whether they've had a previous chronic pain disorder or they have intense pain and are unable to move. It's clear that those patients need more than the standard approach of physiotherapy and exercise and easing back into their activities.
Now, taking MS for an example again, quite a few people report that they had no symptoms of MS until they'd had a car accident. I don't know whether you've come across people that have said that, and it seems to be, I'm not saying it causes MS, they probably had it, but it was benign and they were unaware they had it. And it seems as though something like a car accident can then, a few weeks, months later, they start to get the MS, symptoms, tingling or numbness, that kind of thing. Have you noticed that?
Well, I haven't noticed that per se with MS, but the population I'm seeing is more of a general population. When I did see MS patients who sought me out for help with that condition, I do recall having seen a number who told me that exact same thing. And it makes a lot of sense when you think of the head and neck as one integrated unit. There's very interesting research that has come out over the past couple of years about how the lymphatic drainage of the brain is actually much more important in terms of how the brain heals after an injury. And so anything that impairs the drainage of lymph from the head to the heart may have the potential to create more swelling in the brain. So when we have a vulnerable brain to begin with, and we have a mechanical injury that creates spasm in the neck and constricts the normal healthy drainage of waste products from the brain, then we set the brain up for just being tipped over the edge and turning from a state of being just chronically inflamed to perhaps triggering an autoimmune attack. And that could occur whether the whiplash was just a neck injury or whether it actually included some mild damage to the axons, which is what we see in concussion.
So for people who have chronic pain and they come to you to have this brain test, so would you call it's like what's the chronic pain? I've gone brain dead now. CPRS or something?
CRPS?
Yes.
Complex regional pain syndrome.
So is that as a result of having whiplash in some cases?
Well, CRPS is not very well understood by medicine. It's considered one of these difficult to explain conditions. We call it multifactorial. The way we look at CRPS is that it's almost like a second impact syndrome of the extremity. Usually we'll find that someone has had perhaps a messy wrist fracture that didn't heal well, or perhaps had a dog bite in the arm that was infected for a prolonged period of time, or for whatever other reason there was a pre-existing injury. And then there's a second trauma that leads to this pain syndrome that is vastly out of proportion to what occurred. And sometimes we can see abnormalities in CRPS that actually involve a specific part of the brain, because we know that the nervous system it's a set of wires that goes from from the skin to the brain, through the spine, and back. And so if you've had chronic pain for long enough, we know that your brain changes. And so if we see an abnormal pattern in one specific area that's correlated with the part of the body that's struggling with CRPS, then we know that problem may be amenable to treatment with neurofeedback. And it kind of supports the notion that this is real.
Mm-hmm.
And sometimes more information is required. So I think ideally people have a good integrative provider where they are, and that provider can take over and use the information we've gathered to institute a treatment plan at home. We do a small assessment and a bigger assessment. These sort of two options for looking at what might be affecting people with brain problems. The FBA is a very helpful look at the brain, but it's focused on the brain, and a 2-day assessment, which is more comprehensive and a bit more expensive, looks at other factors, other organs, previous injuries, everything from top to bottom that may be contributing to a person being stuck in their healing.
And on your Q&As, it says, "Why do I have chronic pain?" I've done my homework.
Sometimes the reason that people have chronic pain is because they injured a structure that we can't see. A ligament injury, a tendon injury, somewhere deep in the neck, a concussion syndrome, a spasm of a muscle that has been missed and overlooked. But there's another component to why some people develop chronic pain syndromes and some don't. And it's more along the mindfulness end of the spectrum. It has to do with how you react to the sensations that you feel. So if you have two people who have the same injury, and let's just say that we have a thermometer that can actually measure what they're feeling, and the two are feeling exactly the same sensation, and one person has an approach to life and a personality and a culture and a social background and a whole life experience that leads them to focus on their lives, trust that things will get better, and stay positive and do what they can to take care of themselves. And the other person has a life experience that leads them to have worries about the future, to be nervous about what might happen to them, to be angry that they've been hard done by, to obsess about their problem. All of those factors we label as catastrophizing in medicine. And there's a questionnaire that allows us to measure catastrophizing. And on the day of your car accident, if you answer very highly on a catastrophizing questionnaire, your odds of having a chronic pain syndrome double, everything else aside. So part of the reason we have chronic pain is that there are other factors in our bodies that haven't been treated that require medical care. But the other part has to do with how we react to what we feel. And often the people who end up struggling with chronic pain learn life lessons along the way.
And do some people have higher pain thresholds than others?
Absolutely. And people have pain thresholds that vary based on sex and age and time of day, but they also have inborn differences in pain thresholds. But again, part of the difference between one person and another has to do with how we react to these sensations.
Mm-hmm. I can remember a doctor telling me a few years ago that you should always get rid of the negativity in your life and the negative thoughts, because that would just impact on your health and it's similar to what you were saying.
Absolutely.
Yeah. Because the brain is like a computer, isn't it? And if you just fill it full of negativity, it programs itself into that mode of thinking.
I'm sure you've had discussions on your show about neuroplasticity. and the ability of the brain to change itself.
We haven't gone into it, so that would be really good if you could explain that to us.
Well, we used to think that any injury to the nervous system was permanent, that axons don't regrow themselves, that neurons don't regrow themselves. But that's been completely replaced by a picture that suggests that everything we do, every day we are experiencing life, slightly adjusts our software and adjusts how our brain works, and also adjusts the hardware in terms of the different connections between neurons. So that's describing what occurs at a microscopic level. But what you see in the real world is that the choices you make about what you eat, how you move, how you think, what you do, what you're going to focus on, they can, for lack of a better word, reprogram your brain. And that can happen in a negative way or a positive way. And with chronic pain, it's very challenging to maintain a balance between positive and negative input, because on the one hand, you have all of these symptoms that are inherently negative: pain, stiffness, depression, fatigue, and you have all of this stress about work and relationships and impact on your future. So you have all of this additional negativity, but in addition to that, you have a decrease in the positivity in your life. So the things that you used to do that brought you joy, the things that you used to do physically in terms of exercise or dancing or just being with people, the quality of your sleep, all of those positive experiences you tend to neglect. So you have too much negativity and not enough positivity in your life, and that makes a condition that's going to negatively affect your brain even worse.
Mm-hmm. And then there was another question which I thought was very interesting, and it's, why hasn't my doctor been able to fix this?
Well, it's unfortunate that chronic pain patients have become the lepers of modern medicine. And it's of no fault of their own. It's of no fault of their doctors either. The problem is that we simply don't have good treatments for pain. In the minority of cases, patients will get very significant relief from a prescription or from an injection, or in some cases they may have a surgery that can correct their problem, and they get their life back, which is wonderful. But over 80% of people with chronic pain never get an answer in terms of why they have this problem. And that's simply because medicine doesn't know why this problem exists. We don't have a clear answer because medicine is sort of built around solving problems that, or finding answers to questions that have one answer. And when there's one cause for a disease, it becomes easier to treat. But when there are many factors implicated in a condition, it becomes much more difficult to treat because the treatment is different in different people. In one patient, there may be a need for one approach, and in another patient, there may be a need for another approach. So what patients often hear is, you have to accept that this is never going to go away, or they hear there is no treatment for this, which can be incredibly demoralizing and frustrating. In fact, the message that doctors are intending to communicate is you have to accept that you're in this situation now, and that if you continue to be upset and frustrated about it, you're only going to make your life worse. So acceptance is good, but that doesn't mean that you have to accept that you'll be this way forever. And it's not that there's no treatment for what you have, it's that healthcare practitioner has no treatment for what you have. And so what I tell patients is, if I'm not able to help you, that doesn't mean that you can't be helped, right? Mm-hmm. You continue on your healing journey and you explore one thing after another until you get your health back.
Well, we will just have one more quick break. We'll be back in just a moment. The LDN Research Trust has its own forum, which can be found at forum.ldnresearchtrust.org or via our website. The forum is divided into sections, so it's easy to navigate and find what you're looking for. You can share your experience, ask questions, keep a journal, etc. Unlike Facebook, the posts are always easy to find and don't get buried. We have a private medical professionals only section. To find out more, please email me, linda@ldnrt.org. The Seeker Centre, led by Dr. Richard Nahas in Ottawa, Canada, focuses on pain and the brain by providing assessment and treatment of disorders of the nervous system, using evidence-based integrative medicine and self-care protocols. They're engaged in advocacy, clinical training, research projects and medical education. Call 613-727-7246 extension 114 or visit www.seekerscentre.com. Welcome back. The time is going so quickly. And I love the next question on the website, and it says, what can I do to help myself? And that's really good, because as a patient myself, helping yourself is so empowering, isn't it? It's providing somebody's guiding you in what you're meant to be doing to help yourself.
Absolutely. We've developed a mindset in the modern world because healthcare is so high-tech and so advanced. We've developed a mindset that our health problem is our doctor's job to diagnose and fix. And some of the more proactive patients who I have, who understand that I'm here to help them, but it's their job, are the ones who are the most enjoyable to work with. So what you can do to help yourself is a very long list of things, but usually we try to work with people to identify the things that they feel most interested in trying, the things that they have the lowest barriers to. We try to select things that make sense from our perspective, but also practices that fit into each individual person's life.
I have in the past been asked if LDN helps with brain injuries, and at that time I had to say I didn't know. How do you bring LDN into the treatment plan?
When I see patients who are already stuck on opioids, we identify the getting off of opioids as one of our goals of treatment. And when they are off opioids, then we can consider LDN. For everyone else, The way I approach this is simply a therapeutic trial, which means in my practice we have the LDN prepared by a compounding pharmacist, and it's dispensed in our office, and the bottle contains 60 capsules, which is enough for about 2 months. And I tell patients that we're going to try one bottle, and I want them to tell me within a month how they feel. And if there's no improvement at 1 month or 2 months, then LDN is not right for them, and we'll move on to the next thing that we try.
Mm-hmm.
But if they do feel a response, meaning there's a decrease in pain, there's an improvement in energy or mood or well-being or sleep, or anything else improves noticeably, then it's worth staying on LDN for at least a year, and we'll reassess on an annual basis. And in some cases, patients will opt to stay on it indefinitely.
So, if you don't mind me asking, what dose do you start your patients off on?
I start with 3 milligrams, and if they have no response to 3 milligrams, but they've had no difficulty with sleep and no other side effects, I may try 4.5. Typically, I see a response at 3 if I'm going to see a response. Mm-hmm. I have no data to support that, but that's my impression. And if they do respond to 3, then their next bottle will be 4.5. I simply do that because in my patients who have pain and brain-related issues, they're much more susceptible to sleep disturbances.
Mm-hmm. And for those patients that you give the trial to, what is the dropout rate? How many people, percentage-wise, roughly, I know you weren't expecting this question, that LDN doesn't work for? Does it work for more people than not?
LDN is able to give me a clear impression that it's working in a third to half of my patients.
Mm-hmm. And do any of the patients that stop taking it go back on it because they then realised it was actually doing more for them than they realised?
That does happen. It doesn't usually happen after the first month because patients tend not to drop off so quickly. Mm-hmm. But I do have patients who realize after 6 months or a year, for whatever reason, they stopped, they didn't get around to coming to get more, or they decided they wanted to take a break, or they're financially tight, so they had to discontinue all other treatment, and they find that they're worse. Mm. But it's interesting. There are 2 things that we look for. One is an improvement in symptoms, and the other is a decrease in the duration or intensity of pain flares. And that's another important thing, because many of these patients have adrenal fatigue. And when you've got adrenal fatigue, anytime you subject your body to a stress, and your adrenals can't produce that extra surge of cortisol that you need to overcome that stress, then your whole body just sort of goes into a state of, angry inflammation. And when, for whatever reason, when LDN is working, pain flares are significantly less frequent.
And for those patients who have sleep disturbance, do you ever try them on LDN in the morning?
I can't say I've ever done that. Okay. Have you had feedback on that?
Yes. And there are many doctors now that will actually switch patients to a morning dose until they've stabilised and LDN is in their system, and then change back to evening dosing. And usually they're okay going back on an evening dose, although I know quite a few people who prefer taking it in the morning. They feel it gives them more energy during the day. But that was just
interesting.
And a by the way. But this is so interesting. And with the brain injury, you were talking about concussion.
Mm-hmm.
What other brain injuries are there that result from, say, a car accident or something like that?
Well, that's a good question. Traumatic brain injury is one type of acquired brain injury, and you can acquire a brain injury after a stroke or after brain surgery or after a brain infection, like meningitis or encephalitis. And a traumatic brain injury can be due to striking your head on the vehicle. So a head injury in addition to a brain injury. But it's a myth that you actually have to hit your head to have a concussion. When you're in a car and you're either going from 50 kilometers per hour to zero, or you're stopped and someone rear ends you and that velocity is transferred to your car, there's a shaking of the brain that occurs. And that rapid deceleration of the brain actually stretches all of the tiny little spaghetti-shaped nerve fibers in your brain, and those are called axons. And that stretching can actually cause micro tears in the nerve cells themselves. It's called diffuse axonal injury. And it's that whipping motion that is responsible for the injury that causes all of the secondary swelling and edema and all of the other inflammation around that lesion that causes post-concussion syndrome. And blast injuries in soldiers have been the primary driver for the increased awareness of post-concussion syndrome, because certainly in the U.S. this has become an issue. I trust it's in the media in Britain as well, that many soldiers who've come back from Iraq or Afghanistan are struggling with brain symptoms, whether it's PCS, post-concussion syndrome, or PTSD, post-traumatic stress disorder, or chronic pain, or all three. This is a newly recognized diagnosis called the Polytrauma Clinical Triad, PCT. And it's a brain syndrome that creates symptoms of all of these conditions, pain and concussion and PTSD symptoms like nightmares and anxiety. And so these patients often don't know what's going on with them because they get mixed messages about what their diagnosis is. They'll see a neurologist who says they have concussion. They'll see a psychiatrist who says they have PTSD. They'll see a rheumatologist who says they have chronic pain, and they're often left confused. And what I tell patients is that what happened to them is that they had an injury that resulted in multiple stressors that all affect the brain. So we're going to target all of these different problems by focusing on healing the brain.
And we do actually have a psychologist who's talking about PCT at the conference in September. So that's also interesting.
Oh, excellent.
So
excellent.
The inflammation in the brain, we know that LDN helps with inflammation. Does it also help with the inflammation in the brain?
It seems to, yes, because the housekeeping molecules, the housekeeping cells in the brain, we call them glia, the astrocytes and oligodendrocytes and microglia that are all responsible for cleaning up damage and repairing brain tissue, appear to be regulated in part by endorphins. So, brain inflammation appears to be something that LDN can help normalize.
Mm-hmm.
And we look at other factors that can help modulate brain inflammation at the same time. We know that melatonin can help turn down the heat or the inflammation in the brain. There's interesting research looking at turmeric and boswellia and other anti-inflammatories. We know that the relaxation response and many of the other self-care practices that we recommend, whether it's something as simple as enjoying social time with a friend or spending time with a pet or getting some fresh air and sunlight on a daytime walk, all of these things can modulate brain inflammation.
So if somebody has been in a car accident or they're a war veteran or suffering with some form of brain injury and they don't know where to go to and their doctor is unable to help them find the right path to recovery, where should they start? How do they find the right person to help them, and what sort of protocols would they be looking for?
Well, anyone who wonders if they've had a concussion or not, and if a head injury, whether it be in childhood or while playing sports as a teen or while skiing or during a car accident that happened years ago that they had forgotten about, I think it's worthwhile if you've got any kind of brain-related problem to get a QEEG at some point. And you can do that in your community if you have a neurofeedback practitioner nearby, because most of them are able to get good quality QEEG data. And sometimes their ability to interpret the QEEG may be a problem. And so what some practitioners have opted to do is to send the reports out to professionals who provide interpretations and explain the data so that they know how to use it with their patients from a distance. For patients who are, near our facility, we obviously can do an FBA, a half-day assessment at a moment's notice because it's a quick visit. But we're sort of building the capacity to accommodate people from afar who, for whatever reason, haven't gotten the answers they need and are looking for something more in-depth and more comprehensive.
So if somebody had an injury 20 years ago, and how would it manifest itself 20 years on for them to think there's something wrong here, that I need to have it investigated? How would they know? What would the kind of symptoms they'd be experiencing?
Often there are none. So I can't say that if you don't have these symptoms that you're okay. And in fact, what results from many concussions is just a decrease in performance. People are a little bit less able to focus. They're able to maintain consistent mental work for a shorter period of time than they used to. Their memory is not quite as good. They may be slightly more prone to depression or anxiety, but not in a noticeable way. They would appear totally normal. So this is sort of a way for any person who wants to build their health, to identify problems that they can focus on. And it's a way for anyone whose health is an issue, who feels kind of stuck, to look at an avenue that hasn't been explored yet as a way to help them get unstuck. Mm-hmm. But in terms of symptoms that you can look for, as I mentioned, sleep disturbances, headaches, depression, anxiety, easy irritability, all of those are the kind of the cognitive and emotional symptoms. There's also visual symptoms like just, your eyes get tired if you look at a screen for too long. And by that, I don't mean 3 hours. I mean, in some cases, 15 minutes. Or you have trouble focusing when you're reading because your eye movements are not as coordinated as they used to be, or you've got ringing in your ears and you don't know why, or you're prone to dizziness and you don't know why. Any of those can be symptoms of a post-concussion syndrome.
Wow, it's truly amazing. And we're just coming to the end now, and there are still so many questions I could ask you. It's been very, very interesting. Wow.
Well, it's been a great conversation for me too. Thank you.
Good. Well, thank you very much. As I say, it's been absolutely amazing, and we'll have to get you to share some case studies with us when you have the time. I know you're very busy.
Well, thanks for having me, and I hope we can chat again. All the best.
Thank you. Bye-bye.
Bye-bye.
The LDN 2017 conference will be held in Portland, Oregon, in the US, 22nd to the 24th of September. If you're unable to attend in person, we'll bring the conference to you, regardless where you live. You can participate via our live stream. Check out www.ldn2017.com for early bird discounts. The conference will examine life-changing breakthroughs for treating multiple sclerosis, Crohn's disease, colitis, autism, irritable bowel syndrome, lupus, fibromyalgia, rheumatoid arthritis, chronic pain, mental health issues, restless leg syndrome, and many other conditions using low-dose Naltrexone. For tickets, live stream, and sponsorship opportunities, go to www.ldn2017.com. The Seeker Centre, led by Dr. Richard Nahas in Ottawa, Canada, focuses on pain and the brain by providing assessment and treatment of disorders of the nervous system, using evidence-based integrative medicine and self-care protocols. They're engaged in advocacy, clinical training, research projects, and medical education. Call 613-727-7246, extension 114, or visit www.seekerscentre.com. Any questions or comments you may have, please email me, Linda, Linda, at ldnrt.org. I look forward to hearing from you. Thank you for joining us today. We really appreciated your company. Until next time, stay safe and keep well.